when we think about high value pain care, there's a Lancet article that talks about high value low back pain care. There's also a guideline that came from the national clinical standards around about the clinical standards for low back pain, and then there's a Medical Journal of Australia article that informs that. And really, when you read that article, you realize that what we're doing in primary care, or what even we're doing, even as specialists seeing patients with pain, where that what we're going to first is not really the foundation of care. And what I found explaining to my patients is that we got to get the foundations right before we start building on top of this other things. Because, for instance, when when I was working at quite an interventional unit, a public unit, patients really just wanted they were coming to the pain clinic really because we were going to do injections and medications for them. But really, what we were a multidisciplinary service. We really wanted to form the bottom of the pyramid. And if you think about the bottom of the pyramid, we all know the food pyramid, and the things you do least are at the top, and the things that we want to get right are down the bottom. And down the bottom are things, the simple things. It's about getting a diet right. And diet also means probably weight. It's sleep, getting adequate sleep, fixing sleep. Why aren't you sleeping? It's getting exercise right. We have to move. We have to do, and exercise is a big thing. It's mobility, it's stretching, it's aerobic, it's also strength. It's a big thing. And it's drinking, it's ethanol, alcohol, it's cannabis, and then and that's really forms the foundation. Are we getting that right? Because, and I think my general practice background as well informs that, because that's the thing we need to talk to patients about a lot. And if we're getting the bottom right, we can move up to the next level. And if someone has, and at the next level, there might be medications or more complicated medications, not yet opioids. But at that level, we're doing more informed care with physios collaborating, saying, look, we need to work out the shoulder, what's going on here, what's going on with our lower back. Or it might be neuropathic pain, or it might be post-surgical pain. It might be post-trauma pain, or it might be complex regional pain syndrome. It might be fibromyalgia. We're also involving psychologists. We're also involving education. We're building up the pyramid. So the bottom part is what we can manage properly in primary care, and we can step up. But then as we start going up to the top of the pyramid, we're adding more complicated, more specific medications, opioids, for instance, antineuropathics and antidepressants. And as we get up to the top of the pyramid in pain management, tip is injections, surgery, and I can't remember the last thing it was, and doing things like spinal cord stimulation and things like that. And so what we were talking about offline was that sometimes that pyramid is reversed. And in fact, I've got a picture of that. And where we start at the bottom, we go opioids first, we go injections first, we go scanning first. We just go and neglect the top of the pyramid. And interestingly, paradoxically, all the evidence is at the bottom of the pyramid. All the Cochrane reviews, there's good, solid evidence, level 1 evidence for exercise and low back pain, knee osteoarthritis, hip osteoarthritis, exercise producing good analgesia. It's psychology helping to inform group programs. It's all of these together have the most evidence, and often they're the most neglected. And so I think that the pyramid, which I drew, and I've seen it before again, is really the best way to think about pain. And I draw that right often for my patients. I say, they think we're coming to see the pain doctor. We're going to, look, I'd love to do an injection. Being in theatre is fun. It's great. But it's not going to work for you unless we get the bottom right. And if you come and see me as a pain doctor, I need to make sure that it's right. That's with the whole package.
Yeah, it's amazing. To hear that from you. the importance of lifestyle interventions and behavior change. And I wonder what I have my own ideas around why it's inverted. I think incentive structures, unfortunately, and I'm not saying that all doctors are, yeah, evil and they want to make money and those kind of things, but there is that bias there. On top of that, there's, that habit change is hard. It's really hard to change habits and change behaviors. Those are probably the two primary reasons why I think the pyramid's often inverted. One is to do with the medical system, and the other is to do with patients. And it really just is hard for people to change habits. Why do you think that
Mm.
pyramid's often
I think you're
inverted?
right. Yeah. What you just said then is true. So one of the things that we learn that we really get a handle on in pain medicine is understanding a person, because you were saying before about the patient issues. And one of those issues is, and you would see as well in physio, is pain cognition. Cognition is how do you think of something? Are you more a warrior? Do you catastrophize? Do you have any, do you have comorbid a mental, like a psychiatric diagnosis of depression or anxiety? Are you or have you? And then other things can be like, have you had a history of trauma? And so you have quite a sensitized nervous system. And so one of the biggest things there is this idea of passive and active cognitions. And often the reason why that pyramid is inverted is because people want things done to them. Give me a tablet, do an injection, give me some massage, put on a heat pack, put on a TENS machine. It's active means that you are actually doing something. You're doing the stretch, you're doing the exercise, you're doing the meditation, you're doing the deep breathing, you're going for the walk, you're breaking that fear avoidance cycle.